And so we talk about normal wound healing. So there's 3 phases of healing. So inflammation, proliferation, so inflammation, there's a signal, right? Your body says, I'm injured, it hurts. What happens when you cut yourself? It hurts, right? It's a signal to your body that, hey, send stuff here, right? And that's proliferation. So new cells come into the area, your vasculature changes, there's gaps that open, cells crawl. It's very interesting. If you have YouTube, I can send you guys stuff, but it's very interesting. You can see actually the cells crawl into the tissues and start to heal. That's proliferation, so that's why it gets swollen. And then there's maturation or remodeling. Over time, that tissue heals. And so what happens with the skin, you can see that you get a cut, you get a wound, it heals. The same thing happens in different tissue. And so this is a PRP and paradigm shift that we're looking at regeneration. And so that happens in musculoskeletal tissues, but it's also for skin, for hair. There's other things that can help tissue heal, right? And so that's why there's a lot of interest. We're not perfect at it, but there's a lot of interest in, obviously a lot of money is spent on beauty and aesthetics, and so some of that is being used in various different areas. For pain management and what we do, we're really treating joints, tendons, ligaments, muscle tears. So the question you may ask is this safe? What's really interesting is this has been used in orthodontics and in veterinary medicine. One of our colleagues here in Wilsonville is the head team doctor for the U.S. Olympic team, equestrian team, so horses. And they've been using this for 30 years. And what do horses not do is they don't have a placebo effect. Right? So if they're going to run or perform, they're going to run or perform. And so when they treat them, there's a very good indication of, is this healing? Because they can run, they're not lame. And so they've been using this for a lot of injuries for a long time. And they haven't had any issues with treating yourself with your own tissue. Because it's made by you, it's for you, it's produced by you. So what are stem cells? Who's heard about stem cells here? It's a kind of a big topic. So they're unspecialized. They're basic cells. They can become anything. They're replicable, right? So they can reproduce themselves. And they can become other cell types. That's the neat thing. That when you put these cells into tissue, they actually can become whatever tissue you put them next to. So they're very, very smart. They're very intelligent cells. So for heart, for bone, for cartilage, for hair, for tendons, there's different type of stem cells. So that's one of the things that you have to be careful about, because there's a lot of things going on in the medical community, a little bit unscrupulous. You have to be careful, because when I take stem cells, what we do, we take stem cells from your bone marrow, we take stem cells from your fat. They're really good at becoming cartilage, they're really good at becoming tendon, muscle. They're not good at becoming pancreas, right, for diabetes. They're not good at becoming hair. They're not good at becoming other things. They can stimulate some growth, but they're not good at becoming those things. But there are cells that can. And so what we're looking at is the specialized cells. So when they start to, so you have the embryonic stem cell, and we're going to talk about types of stem cells. So embryonic, those are your basic, embryo cells. They can become pretty much anything. They're very unspecialized. As they start to go down the lineage, they start to lose some of that differentiation, and they start to become more specialized. And so those are adult mesenchymal cells. That's what we use. And there's certain things that they can become, and certain things that they can't. So we have to be smart about what we're using. And then there's IPC, and you're going to hear more and more about this, and this is where technology, and you guys are going to be involved, is that you can take these adult differentiated stem cells, and you can backtrack them. You can reverse some of that knowledge, and you can get them into pluripotent cells, so they can become anything. So that's really fascinating. So those are iPSCs. So you're going to hear more and more about that in the community, because we're going to be able to take those cells, and then they can become whatever we want, and they can regenerate. So what I like to say is platelet-rich plasma, it's like the mortar. So if you have a tissue, we saw that tendon, it's kind of degenerated, it's breaking down a little bit, the wall's broken, and you need some mortar to stick things together. That's the platelets, that's the sticky glue, right? Stem cells are when the wall looks really bad, and you need new bricks, you need new cells. Another analogy that I like to use is, I'll do a couple. Here is the stem cells are the seeds, and the platelets are the fertilizer, right? So think about it that way. Now how do we get stem cells, or how do we get that material? The platelets is easy. We just go into your blood. We do a venipuncture, go into a vein, draw the blood, spin it down, and get that platelet layer. For the stem cells, it's a little bit more difficult. We have to actually go into your bone marrow. For bone marrow stem cells, we do a little bit of liposuction. So take some fat and mix those together, concentrate that, and then inject that into the tissue. So those are the couple of things that we do. So the harvesting procedure is very interesting. That's where we use the imaging modality. So I can guide the needle into bone, into your iliac crest, into your bone marrow, and then I can use ultrasound to look at the fat and get the fat. And then we have a lab that spins it down, centrifuge, basically breaks up the different cell types, and then we can concentrate that. And the third step is to place it where you're having pain or injury. Another interesting thing, so we talked about the growth factors. There's a really wonderful source of growth factors in amniotic membrane. And this is something that's I'm very interested in. But there's a chorion and amnion. It's the membrane that separates the mother and the baby. And basically what that does is supplies growth factors, and it's a transport mechanism for this fetus that's developing. It's very rich in growth factors. So the same things in platelets. So when the platelets break down, they release all these growth factors into the environment and stimulate healing. The same thing is in the amniotic membrane. And what's really interesting is that because it's between the mother and the baby, it doesn't have HLA antigens. So you can't reject it. So it's really nice that you can use that tissue for anybody. So you can inject it to anybody who's not going to fight it, because your body doesn't recognize it as foreign, because we don't want to recognize the fetus as foreign. Right? We want to stimulate that and nurture that and have that baby grow. So the amniotic membrane is a tissue. And so right now it's the standard of care for wound healing. In the last 5 years in the VA system, for all these wounded warriors or people that are vets that are injured, they take the amniotic membrane. So it's a membrane, it's like a sheet of tissue, and they cut these membranes, and so they take grafts from that and they put it on tissue. It used to take 6 months for a full thickness wound. It used to take 6 months and about 30 graft replacements of, they used to use pig bladder. It sounds kind of arcane, but that's what they used to use for healing. That was the standard of care. Now they're using human amniotic membrane, and it takes 2 applications and about 30 days to heal. It's a profound difference. But imagine they take this membrane and they take all these grafts. What's left over? Swiss cheese, right? So they have all this stuff and they were throwing it away, and they said, what do we do with that? So they started to micronize it, and then you can inject it. You can mix it with saline and inject it into tissue. And what we're seeing is that it's healing. And so you can see this is what it looks like. It's that thin membrane. And so that's something that we're looking at. So that's where technology comes in, that we're looking at a lot of different possibilities. So we're isolating those growth factors, we're isolating these materials that can allow us to heal better and basically go from this broken to fixed tendon. One of the impressive studies was done. There's 204 patients with shoulder pain. Right? Who's had shoulder pain in our audience here? Right? So shoulder pain, probably your age, young people, rotator cuff, right? It's rotator cuff, frozen shoulder, and so it's soft tissue injury. So they did a study of people. They took 204 patients that came in with shoulder pain, rotator cuff tears, and they injected half with the steroid, which is the standard of care, and they injected half with platelet-rich plasma. What was really interesting is that at a year follow-up, 3 patients that had had injections with the platelet-rich plasma had surgery for pain that didn't go away. And with the steroid group, 48 patients out of 100, so almost half, had to have surgery. And so obviously there's a massive difference in the healing capacity. And imagine the cost savings to insurance, to businesses that take this approach. What was interesting as well is this is a study from Stanford University. When they injected the platelets into soft tissues in athletes, they started to measure blood levels. They're like, what's happening systemically? Like, you're causing this tissue to heal. Is it only local? Like, if we inject your knee, is there only a local effect? So they started to look at their blood work, and what they found was there was massive increases in their blood levels of certain substances. And some of these substances are used for performance enhancement, right? So if you're an Olympic athlete, we've heard about Lance Armstrong and all the other things that they're doing. So there's lots of substances that you can put into your body to enhance performance, enhance healing, put you in an anabolic state. And what was interesting is that when you did an injection of this material, concentrated and stimulated the body, those levels dramatically increased. So not only were you healing in your knee, you're actually healing in other places. So we're turning on systemic pathways for healing. And one of the things we started to do with these injections, and we noticed that we had a cohort of MMA fighters. And those guys were super fit, and who knows what they were taking to get to that level, but they were taking probably anabolic steroids and other things that were performance enhancing. Not that we're advocating that, but they were in a building phase. And when we injected them, they healed faster than anybody I've seen. It was pretty impressive. Now that doctor who was giving them that medication actually got in trouble, so we don't want to go down that pathway. But what we noticed is that patients that were healthier healed faster. It makes sense, right? If your system is working better, what's going to happen? You're going to heal faster. So that process took, what we have in our practice now is we really look at the whole patient. So if someone comes in and they're diabetic, they're overweight, they're not taking care of themselves, are they going to heal as well as other people? No, right? And so what do you need to tell them? So you have to start getting healthy. I can give you these fantastic shots, but if you're not taking care of yourself, you're not going to heal. And so that's really important. And so this is a picture here. So the tendon, sometimes we'll get calcium next to it. And so what I think of it like is an M&M sitting on top or in the tendon. So what we want to do, the chocolate in the M&M really makes the tendon angry. It causes a lot of pain. Okay, it's called calcific tendonitis, and you see it all the time. And so what we want to do is get rid of the M&M, and we want to heal that tendon. And so this is an example here. And you see this is a rotator cuff. So shoulder pain, this is an MRI. So this is the ball, and that's the socket, and this is the tendon that comes over and attaches to your. So what happens when this muscle contracts? So if that muscle contracts, what's going to happen? You're going to raise your arm, right? So the rotator cuff is responsible for that first 15 degrees, so getting your arm off your side. That's rotator cuff. That's supraspinatus. After here, deltoid kicks in, right? So your deltoid muscle. So this, when that contracts, that pulls it up. There's a big M&M sitting in there. Okay, and so that makes it really angry. This is a fluid-sensitive sequence. So on the MRI, we can look at inflammation. So the bright stuff there is angriness. That's fluid. That's inflammation, right? So this is inflammation, and it's right around that M&M. So we have a technique. We can go and we can put a needle in that M&M, and what I tell my patients is we're going to take the chocolate out. We're going to get all that chocolate out there. And so we were able to do that, but what happened with this patient, this was a professional drummer. That's his career. He couldn't drum. He was having a lot of pain. We took the M&M out, or most of it out, but the tendon still looked bad, right? So we want to see a nice rope, and that rope looks like this frayed rope. And you can see these areas where there's still a little bit of chocolate and some breakdown. So inflammation, that's called bursitis. There's a bursa that overlies the tissue, and there's holes in the tendon. So we went in there, and we put that amniotic membrane, those growth factors, into that tissue after we washed the tendon out. This is a picture. I hope this works. I'm pretty computer unsavvy. Are you able to play the movie? If not, I can tell you verbally what that should look like. But not playing. Oh, good. So do you see how that got cloudy? So it's clear. If we can restart it, that would be. Can we move it? Okay, so we're going to go back. See how that's clear there? Now watch what happens. It's white chocolate, right? So you see that white stuff coming back in? That's the calcium. So it's really, I love this procedure. It's really fun. Because then you can give them the calcium to take home. And so this is why you were hurting, and they take it home to their family, and they show them, look, it wasn't in my head. So it's a really fun procedure. So you take that calcium out, but the tendon was still broken down, right? So now you have one process, you have to treat the other one to try to heal the tendon. So that's when you injected the growth factors, and look what happens over time. And so that's called healing. So see how that tendon looks more normal? It looks more like a rope. You see those fibers coming in? So as radiologists, we read that as like that bottom one would be read as a normal rotator cuff insertion. The top one, degeneration, wear, and tear. That is not. If you show that to an orthopedic surgeon, you show that to anybody in the medical field, that's not real. That's not reality. That doesn't happen. You need surgery. So that's a paradigm shift. So you guys are seeing kind of when we talked about the futurist and biohacking, this is what's happening, right? We're able to take tissue back, and it can happen. This is another patient that had a knee pain. So it was a basketball player, and we had a tear. And I said, you guys are going to be fantastic musculoskeletal radiologists. We're going to send you some films to read. This is a normal tendon here. This white is inflammation. There's diffusion in the joint, swelling in the joint. And there's a small tear in that tendon with severe pain, even though it's 1 or 2 millimeters, completely incapacitating for the patient. So that's the initial MRI. The ultrasound shows beautifully the type 1 collagen fibers. So you can see those fibers extend into this area, and see the dark area there? So these are the type 1 collagen, and that dark area corresponds with this dark area here. And the tissue is soft, and so it's breaking down. And you can inject that tissue with a needle. And so you can precisely place it. You can see when we injected, we place a needle there, that dark area, you see the brightness in that dark area? It fills that soft tissue. And 5 weeks later, that tissue is healed. Right? And the patient was pain-free. And the other thing that went away is the fluid in the joint. You see the bright areas? That's also gone. So that's called effusion. When patients come in, they have swelling in the knee. So not only is it fixing the tendon, it's fixing that tissue. This is another example. This was a forest ranger that tore his tendon is attaching to his elbow. Have you heard of tennis elbow? Right? That's what this is. And so that tendon should be nice and dark and attaching to the bone. But you see the white area? So it's here, it's dark. That small area, that tiny little micro tear, completely couldn't work. Right? And so he came in, and the normal thing is to do a steroid injection. I told him, I said, I don't think he needs a tear. He needs, the platelets. But the insurance, the standard of care is steroid.